So without further ado, and hopefully relatively on time, let me introduce again Dr. Pamela Kunz. She's a medical oncologist and a specialist here who has been a wonderful member of the community and increasingly a leader in the community to talk a little bit about immunotherapy. Will it work for NETs?
Thanks, Ron. Thanks, everybody. So it's a pleasure to be down here. I see lots of familiar faces. I love coming to the Cedars conference. And if Lindsay's around, can I still have the 20 minutes? Does that work? Okay. Okay. I'll try to stay on time. Okay. I have some disclosures. I do a lot of clinical trials research and collaborate with a lot of sponsors. I think, as Ron mentioned, some of those are here. So the outline. So we are going to do some basics on immunology, just remembering back to your high school biology. Talk about the current status of cancer immunotherapy in general. It's a very exciting time and a very hopeful time. And then we'll talk about NETs and immunotherapy. So can we apply this to NETs? So to start off, so let's talk about the basic biology of immunology. So there are really two main types of the immune system: the innate immune response and the adaptive immune response. So the innate immune response is really what helps us fight off infections. It's a more rapid response. It includes things like white blood cells that are included. Here, let's see if I can do this. So these are all different types of white blood cells. Granulocytes is a fancy name for white blood cells. There are other types of cells that help out in this more rapid response. Macrophages, for example, are kind of a garbage truck of the immune system and help take away dead cells. There is an adaptive immune response, or a more slow response that builds over time. Things like building antibodies. So B cells help produce antibodies. And we're going to talk a little bit more specifically about T cells. Let me go back. So these are the specific components of the immune system. So B cells, as I'd mentioned, are a type of white blood cell. They make antibodies to proteins. Those proteins are called antigens. So some of these is some of the language we'll continue using and referring back to for this talk. T cells are also a type of white blood cell, and they can kill cells that are recognized as foreign or diseased. And T cells have receptors, which receptors are also a protein on the surface. They help recognize some of these foreign cells. And they are also designed to kill virus-infected cells or potentially cancer cells. Dendritic cells were also on that figure previously and help educate our T cells to tell them which cells might be bad. And then, as I'd mentioned, the macrophages help clean things up. Now, the T cells are important as we talk a little bit further about our new immunotherapies or checkpoint inhibitors. There are a bunch of different types. I just wrote down two here. There are killer or cytotoxic T cells that kill cancer or virus-infected cells. And then there are suppressor T cells or Treg cells that block those other cells. They block the killer T cells. And then the checkpoint inhibitors, if you think of, for patients that have cancer, our body right now, the bodies really prevent us from recognizing a cancer as being foreign. There are stop signs that are up, these suppressor T cells. And if we could figure out a way of removing that stop sign or essentially blocking the stop sign, sort of a double negative, it would allow our body to help fight the cancer. And we'll talk some about that. So let's talk about what successes we've seen so far in other cancers. So as Ron mentioned, can we borrow principles for how we treat some other cancers with immunotherapy and apply that to NETs? So this is that same figure that Ron showed. This really, 3 years ago, immunotherapy was really a brand new field. Those of us who'd done medical school now many years ago thought, we have to go back and learn about immunology, because all of a sudden we were having new therapies that were very exciting and leading to incredible responses in cancers that were otherwise not doing well. So melanoma was really one of the first cancers in which this was studied. So This is a slight modification on what Ron talked about, but there are essentially some of these sort of 3 key ways that we can target the immune system in terms of therapies. So the checkpoint modulators are the ones that I just mentioned. We're going to focus most of this talk on those. Those are the taking away the stop sign to help your immune system fight cancer. Those target a number of different receptors on T cells and on the tumor cells. And those are included here. We'll talk about those in a little bit. Vaccines, so Ron mentioned that as well. Can we activate tumor-specific T cells to induce an immune response? And then also cell-based therapies are these manipulated T cells, the CAR T cells. Can we personalize T cells to help a patient fight cancer? I put this timeline up not for you to read all of the details, but really the field of immunotherapy is actually not all that new. It dates back many, many years, but it's only really been recently that we've been able to apply some of those advances to treating cancer. So I'm going to highlight just a couple of these, but the timeline, for those of you who can't read, dates back to the late 1800s of treating cancer with bacterial products. I'm going to highlight a few that are pertinent to NETs. So some of you may know, so interferon was long used to treat NETs, has actually been in some recent clinical trials. It's really one of the original immunotherapies and actually has given us some rationale for why we may even think about using immunotherapies in NETs. That was developed back in the mid-'80s and used initially in treating melanoma. Additionally, thinking about using viruses is something that I'll mention briefly with an oncolytic virus that's being developed in Sweden by Dr. Kjell Oberg. And then thinking about vaccines. So there was a vaccine that was developed for prostate cancer back in 2010 and really was the first cancer vaccine. And I think, again, all of these have been very exciting advances. And then I added up here some of these new checkpoint inhibitors that have been developed since 2010, and I'll talk about which cancers those are developed in. So here is sort of the take-home of some of these checkpoint inhibitors. So there are 3 main drugs. One I did not put up here. It targets a different receptor called ipilimumab, targets anti-CTLA-4. I'll mention that in the context of the trial that I'll talk about. But all of these, just to give you a little kind of tips on what these drugs mean. So anything that ends in an AB is an antibody. So that's your tip on how to read through these. They all have funny long names. Their brand names are often a little bit easier to say. But nivolumab has been approved now for melanoma, kidney cancer, and lung cancer. Pembrolizumab, also called Keytruda, is approved now for melanoma and lung cancer. And then just a couple months ago, atezolizumab has been approved for bladder cancer. So really exciting. As an oncologist, I'm a GI oncologist by training. I really focus most of my clinical care on NET patients, but almost on a daily basis, we get new data on how some of these agents are working in other cancers, and it's very exciting. Okay, this is a figure that is used to describe how many mutations we see in a given cancer. So many of us know that as cancers develop, they can develop because of mutations that make cell division and growth go awry, and as cancers grow, they can acquire new mutations. What's interesting is that historically, these immunotherapies tend to work better in cancers that have a higher mutation burden. So to give you an example, so you can see, so this is the further it is on the right, the higher the mutational load. And the lower it is down, the lower the mutation load. So you can see melanoma, lung cancer, bladder cancer, kidney cancer, kind of all on the top end here. Microsatellite high colon cancer refers to a very specific subpopulation of colon cancer associated with an inherited risk of developing cancer. Lots of small mutations present in that specific subtype. You may say, well, where are NETs on this graph? Way down at the bottom. So, but how can we overcome that? And actually there is some recent data to suggest that there are ways of doing that. So this is not the only thing that is going to predict response to immunotherapies. So don't despair. All right, so let's talk about NETs and immunotherapy. So I'm going to start with a case. I've borrowed this from my one of my mentors, George Fisher. So this is a patient who developed actually run-of-the-mill colon cancer twice, in fact. So back in 1996, had a stage 1 colon cancer. In 2015, had another colon cancer. And then in 2016, developed liver mets, or liver lesions we thought were going to be colon cancer. But lo and behold, the pathology was actually a neuroendocrine tumor. It looked like a well-differentiated tumor with the way the cells looked, but the Ki-67 was actually quite high. We re-reviewed the colon cancer, and it actually showed that it was a NET. Some of you may have experienced it. I think having really experienced expert pathologists on your case is a really key part of that multidisciplinary team. And then I mentioned before a certain type of colon cancer, or an inherited syndrome called microsatellite instability, that causes lots of little DNA mutations and changes, predispose people to having a syndrome called Lynch syndrome. This patient, actually, you can see they had multiple cancers. This patient had microsatellite instability that would predict for potential response to immunotherapies I showed you on that last graph. So because the patient had that grade 3 NET, they received platinum etoposide, as we had talked previously. That's really the textbook answer. But the cancer grew. You can see here a picture. This is the liver with a couple of spots in the liver. The patient was then put on a clinical trial with one of those checkpoint inhibitors called pembrolizumab that hits the anti-PD-1. And after 2 months of treatment, there was really marked reduction in size and number of liver metastases. So on the left, did I go back? On the left was before, and on the right is after. So this larger lesion here shrank down quite a bit. So I think this was just a nice highlight. It sort of blends some of the things we've talked about, but to think about, can we apply some of these to other cancers? I think the answer is yes. So I'm not going to dwell on this, but only to say I think the field of immunotherapy and NETs is still in early phases. I've started where I think we sort of are with NET research. We're still some in the preclinical, as Ron said. We're funding a lot of preclinical lab-based or mouse research. Those are important because they're the foundations of how we build clinical trials. Phase 1 test safety, phase 2 are starting to look at how effective the drugs are. So we're getting there, and I'll show you some of the trials that are ongoing. So I'm going to talk just very briefly about some of the preclinical trials. So there have been some studies that came out of Europe. These were presented at the European Society of Medical Oncology, really just defining, does it matter if we can find those special proteins, the PD-1 or PD-L1 in the tumor cells? In some of the prior studies with melanoma, it actually mattered for patients. If they were tested and were PD-L1 or PD-1 positive, they had a better response to those therapies. We're in fact just early on finding some contradictory information in NETs. And in this study by Dr. Chives, we found that actually about 69 and 53% respectively of these tumors and the surrounding cells actually were positive for the PD-L1 and PD-1. On a subsequent study, interestingly, the rate for the well-differentiated neuroendocrine tumors was really low and higher for the poorly differentiated NETs. So only to say, I think this field is really just at the beginning. We're trying to learn, actually, does this even matter? And I think the answer is probably no. So a lot of patients, when I see them in clinic, say, I need to have PD-L1 or PD-1 tested. I think we probably don't necessarily need that. We're probably going to study it further, but for right now, that's probably not going to be a requirement for the NET trials. I'll mention just briefly, Ron mentioned the study at UPenn where they're developing specialized or personalized CAR T cells. So I'll just define those a little bit for everybody. So essentially T cells, so it's an acronym, it stands for chimeric antigen receptor T cell. These T cells or special white blood cells are removed from a patient's body and they're modified so they express a special receptor that's specific to that patient's cancer, and then they are reinfused into the patient. So using that somatostatin receptor that's very unique to NETs seemed like a very an ideal target for this. So this particular trial is in the preclinical phase. So it's not yet ready for patients. It's being tested in mice and in test tubes, but we hope we'll get to patients at some point soon. I'll skip over this for a moment. So that was the UPenn study. Dr. Kulke, who's at Dana-Farber, is also doing a preclinical study, really trying to better define this immune environment for NETs. So do they express PD-1 or PD-L1, or are there any other immune markers that are unique to NETs? I think if we have a better understanding of the biology, we may have better success for treatments. So again, this is not yet ready for prime time. They're just starting to get their data. Now this table, again, is busy, but I want the take-home from this to be, look at, these are all of the NET clinical trials that are ongoing or soon to start. I think if I had tried to do this slide a year ago, we would have had none. So it's actually really exciting. So some of them are US-based and some are not. I'm going to touch base on 3 key ones in bold here, and I'll move on. So there is a large multinational clinical trial that's being run by Merck using pembrolizumab. And as I mentioned, that's the anti-PD-1. So this means that this will be available at a number of different sites throughout the US. It's being used as a single agent. And this trial is actually intended to look at a lot of rare diseases, including NETs. And so this is a phase 2 trial, meaning it's starting to look at efficacy. All patients will receive pembrolizumab, so there is no placebo on this trial. And it opened in December of 2015. I know it is open at UCSF. There may be some other centers in California, I'm not sure. They're looking at response rates, so does the cancer shrink? And in terms of eligibility, again, I think it's carcinoid and PNET. I'll mention just briefly a trial that's happening in Sweden, just to touch base on a different approach to immunotherapy, and that's oncolytic viruses, and it's called the RADNET trial being run by Dr. Kjell Oberg, who's really one of the pioneers in the NET field. So they're looking at vaccines and that are viral-based vaccines that are engineered to selectively kill tumor cells. And there is a precedent for this in, as you see on this last bullet point, for melanoma, using an oncolytic virus for melanoma. This trial in Sweden has just started. I'll kind of go over the design of the trial. They just enrolled their first patient in March. They're still in the phase 1 portion, which is testing safety, but they have plans to move this along into phase 2. This particular treatment is actually a treatment that's injected into the liver. It's intended to stimulate a complete body immune response, so not just within the liver. And then lastly, I'll touch base on the trial that we've received funding from Net Research Foundation on that we hope will start soon. We've had some delays, but I think we're summer, fall, Ron. So this is a trial combining 2 immunotherapy. So we really think that this approach will help overcome that issue that NETs have a low mutation burden, or that they may not be PD-1 or PD-L1 positive. So the thought is, let's combine 2 of these checkpoint inhibitors. So it's using ipilimumab and anti-PD-L1, or the atezolizumab was just approved for bladder cancer. The ipilimumab will actually be injected into 1 tumor lesion, so intratumorally, and the atezolizumab will be given intravenously every 3 weeks. Again, the purpose for giving the intratumoral injection is also to generate a systemic immune response. It's a small study of 20 patients. We're going to be looking at both safety and responses. And I think a really key point that I should have mentioned this is really assessing safety. What I didn't mention with all of those approved immunotherapies is that, there is this perception when I see patients that they think it's natural because it's just stimulating your own immune system. But there are indeed a lot of side effects that can come with these therapies, including inflammation or sort of revving up of the immune system in other organs, like colitis that causes diarrhea, or an inflammation of the thyroid or the pituitary gland. I think as we're learning more about how to treat those side effects, they will get safer to use, but I think that they are not without side effect. This is just the design of the trial. As I'd mentioned, we're essentially, with both of these agents, ipilimumab and atezolizumab, sort of removing that stop sign. You're taking that stop sign away to allow the immune system to fight cancer. So this particular trial will allow all types of NETs. It will allow a slightly higher Ki-67, up to 55%, for reasons that we discussed earlier on the panel. Patients will need to have had at least one prior treatment and have progressing or growing tumors prior to being considered. So I think this is a very exciting time. I think just to think about, so my senior mentor, George Fisher, has been doing this longer than I have. He's on the scientific board for Net Research Foundation. And I think, most oncologists are wary to mutter the C word or the cure word. And I think George has said, he's not retiring because of immunotherapy, because it's truly a very hopeful, exciting approach to treating cancer. And, I think it holds promise in NETs. It's a little early to know for sure, but I think lots of investigators are committed to trying to make some of these immunotherapy trials happen. We really need a better understanding of the NET immune environment and figuring out how to overcome some of these obstacles, such as that low mutation burden or lack of PD-1 or PD-L1 positivity, but I think that there are some approaches to do that. So I look forward to updating you in a couple of years when we have some results on some of these trials. So thank you.